Hi, everyone. Good morning. It's so wonderful to see so many people here, and I really thank you for the opportunity to talk to you today about pediatric long COVID. Where do we stand? Okay, so I always like to start my presentations with the words of families so that we can hold these close to us during this time. And so I'm going to share quotes from families with children of different ages. So first, this is a mother of a teenager. So she says, "My teenage daughter had COVID in December 2022, and months later, she is really struggling. She has been out of school for 6 weeks with debilitating fatigue, pain, and brain fog, none of which show any sign of letting up. All in all, COVID has been a devastatingly difficult journey for my family, and it's not one I wish on anyone." A mother of a school-age child shared, "For over 3 years, long COVID has derailed my family's life. My 11-year-old with long COVID has missed over a year of school due to long COVID-induced fatigue, brain fog, POTS, and celiac. And my own long COVID journey has made caregiving a balancing act. With our lives turned upside down, we wait for a clearer path ahead." And finally, a mother of a young child shared, "When my daughter was 5, I dropped her off at school and didn't even leave the parking lot before they called me back. She had passed out on the carpet and was too weak to sit up. That was 2 years ago, and I took her to the doctor that day and learned it was long COVID. Now she is able to go to school most days, but when she catches an infection, it can take her 2 weeks to recover." So I wanted to share these quotes to honor these lived experiences, and it really highlights the urgency of why we need pediatric research for long COVID. And so this is so urgent because still, most of what we know about long COVID, we know from studies of adults. And when it comes to long COVID in children, there are many more questions than answers. This really stems from several common misperceptions. These misperceptions include children do not get long COVID. And if they do, they must have symptoms that look the same as those of adults. And if they do, they must get better quickly. And we know that these statements are not true. And they really have led to a significant under-recognition that long COVID is a public health crisis for children. So we do know that long COVID is a significant public health problem for children. And while the estimates of prevalence have varied really widely in studies, it is likely that the range for children is between 2 and 10% of children who have had a SARS-CoV-2 infection may develop long COVID. And if we consider what those numbers mean, in the United States, if there's an estimated 65 million children who were found to be antibody positive, this might be between 1.3 and 6.5 children in the US who may have long COVID. And when we compare that to other common conditions, we have 4.6 million children with asthma, commonly known as one of the common conditions of childhood, 500,000 with epilepsy, 15,000 diagnosed with cancer each year. So this really highlights that long COVID in children is not a rare condition. So what does long COVID look like in children? Well, similar to adults, long COVID in children is a heterogeneous condition, collection of symptoms, with different symptoms presenting in different children. And the symptoms can occur in almost every organ system of the body. And what about the natural course or the trajectories of long COVID over time, when people are saying that children recover quickly? Well, more research is needed in this area, but one of the first long-term studies came out of Rome, Italy, a prospective cohort where they followed children with confirmed SARS-CoV-2 infection in a post-COVID clinic for up to 3 years after their infection. And of the 1,200 patients that they were following, 77% recovered by 3 months following their infection. But of those that likely had long COVID, they were seeing 87% recovered by 6 months, 92 by 12 months, 94 by 18 months, and then this relatively plateaued. And this is similar to the patterns we're seeing in adults, where there's a substantial deceleration of recovery by the 6 to 12-month period. And it really was one of the first studies to truly highlight that there are these long-lasting, persistent symptoms after SARS-CoV-2 infection. And while many children can improve over time, there are still highly symptomatic children, even by the 3-year follow-up period. And as we've heard this morning, there are significant long-term impacts. In children, there are educational costs with substantial missed school and reduced activity. And then there are health costs, social costs, and economic costs. So we really must invest in making these children better. And there have been many potential contributors that have been proposed as underlying mechanisms for long COVID. We talked about a few: viral persistence, increased inflammation, reactivation of other viruses, change in the gut microbiome, clotting problems, or an increased active immune system. But most of this research comes from adults, and whether these potential mechanisms might differ for children still remains unclear. And so in the United States, the RECOVER initiative was founded to help to fill many of the gaps that I mentioned. And so RECOVER stands for Researching COVID to Enhance Recovery, and was really designed to study the long-term health effects of COVID across the entire lifespan in order to prevent and treat long COVID. And I'm going to describe to you the observational cohort study. So it's really, in the United States, a national project. There are over up to 40,000 people of all ages and races and ethnicities enrolled across almost every state. And for the pediatric study, we have over 22,000 participants contributing data across over 100 sites. And this is a large cohort that reflects the diversity of the United States. And so this really summarizes a picture of what our main goals of the RECOVER pediatric study are. And we enrolled participants through the entire pediatric lifespan, from birth all the way through young adulthood at 25 years old. And we enrolled children with a history of a SARS-CoV-2 infection, and we enrolled children without a history of a SARS-CoV-2 infection to serve as a comparison group. And one of the first questions we really wanted to tackle was, how does long COVID differ by different ages, by child age? And so we started to characterize long COVID based on symptomatology by different ages. And we published in JAMA a paper characterizing long COVID in school-age children, 6 to 11, and adolescents, 12 to 17. And one of our main initial takeaways was that symptom patterns are similar, but distinguishable across age groups. And one of the things we were seeing was that there are different symptom clusters or different types of long COVID that children are experiencing, and these also varied by age. And so in the middle, we have clusters of symptoms that are experienced by both school-age children and adolescents, and these are also commonly seen in adults. where we have one group of children that are experiencing many symptoms across multiple organ systems. And then we have another group where their predominant symptoms were pain, fatigue, and low energy. But then we also saw unique clusters specific to school-age children. We had one that was predominated by trouble sleeping and trouble with memory and focusing, and another that was predominated by gastrointestinal symptoms, stomach pain, nausea, and vomiting. And then in adolescence, we saw a unique cluster where the primary symptom was change in loss in smell and taste. And then we thought, well, what about the earliest kid, the youngest kids? What about early childhood? So we recently published a paper in JAMA Pediatrics highlighting and characterizing symptoms in early childhood. And what we found was that the most predominant symptoms of long COVID in early childhood were ones that were most observable by caregivers. And so in infants and toddlers, the most common symptoms were trouble sleeping, fussiness, poor appetite, stuffy nose, and prolonged cough. And in preschool-age children, we saw prolonged cough as well as daytime tiredness, sleepiness, and low energy. So what are the implications of these findings? Well, these findings can really help clinicians, healthcare teams, and families by raising this awareness about long COVID and showing that children of all ages can develop long COVID, and their symptoms are variable across these ages. And this is critical that we try to understand now why these age differences occur in order to create future long COVID treatments for children that are likely going to need to be age group specific. And so how do we do this? How do we learn about the underlying mechanisms and continue to identify targets for treatment? Well, this brings us to our longitudinal phase of our Recover Pediatric study. So we are continuing to follow these children for up to 4 years and incorporating many different types of data modalities, including clinical data and biologic data, in order to further characterize these subphenotypes. We are evaluating potential risk and resiliency factors and investigating these underlying mechanisms in order to develop interventions and refining these definitions as we learn more over time. So we are following these children for up to 4 years. After our baseline assessment, a large subgroup of about 3,000 children are being followed for in-person visits at 6, 12, 24, 36, and 48 months after their enrollment. And a subset of those most severely affected are also participating in our most intensive phase. And to date, we have a tremendous amount of data on children. We have over 20,000 symptom surveys collected, over 5,000 office visits. We have neurocognitive testing, flexibility testing, 40,000 different laboratory results, as well as over 23,000 biospecimens that have been stored for ancillary studies. And I wanted to highlight a unique aspect of Recover, which is our Systems Biology Award, where across the entire age spectrum, both adults and children, but this includes 3,000 children, we are going to be having comprehensive multi-omic data generated on this longitudinal cohort over time. So this includes genomics, transcriptomics, epigenomics, proteomics, metabolomics, and so all of this can be used to help us to identify underlying mechanisms and biomarkers and foundations for treatment. And so the aims of this are really to make this link between pathophysiology and potential treatment targets, characterizing the pathobiology, further defining the long COVID subtypes by biology, helping us to predict prognosis and develop diagnostic tools, and ultimately identify treatment targets. And all of the data for RECOVER is publicly available. I wanted to highlight that there are mechanisms for accessing RECOVER observational cohort study data and mechanisms for applying for ancillary studies. And so this is all available to the scientific community and the public and help to support researchers both within and outside of RECOVER to submit ancillary studies. And there are open proposals right now. The data is stored in a cloud-based research ecosystem called Biodata Catalyst and available. And these are the websites that are linked here. I also wanted to highlight that there is a webinar series upcoming being led by RECOVER to really spread the word about how to do this. And so there are 2 dates that are listed here and a QR code for registering. Then this will really go over how to access RECOVER data and how to access biosamples to advance research. And then, one of the common challenges we hear from families is that physicians and people, schools, they don't know enough about the research happening in children with long COVID. And so how do we disseminate this work as quickly as possible? And so this is really challenging. But one of the things we're doing is really continuing to partner with patients and advocates. And we in RECOVER Pediatrics work very closely with an advocacy organization called Long COVID Families, the largest advocacy group in the United States, focused specifically on children. And one of the things we do is, you can see this infographic here based on the papers that I discussed. Within days, their website has these infographics up for dissemination. And they have also made requests of children living with long COVID to submit artwork really representing what this experience is like for them. And I highlighted some of the beautiful ones here. There's a teenager who really feels like she's underwater all the time. And another teenager who's angry and screaming and crying because people are always saying, "You don't look disabled." And I highlight these because they are powerful messages. And even in advocacy trips to Washington, where this group went to talk to the Senate, these pictures were being handed out so people can really understand what's going on in people's lives. I also wanted to highlight, along with these manuscripts, we wrote a JAMA pediatric patient page, which is a free downloadable page by the journal. And we hear from our families that they're printing this out. They're actually bringing this with them to the doctor so that they can come with the evidence that long COVID is real, and it may look different in different age children. I also wanted to highlight something outside of RECOVER. There's a partnership funded by the CDC and through the Council of Medical Specialty Societies that has really put together something called Long COVID Education, Engagement, and Care Management Project. And this is a federally funded project in the United States that's seeking to provide multidisciplinary coordination and collaboration across our medical societies to improve provider education and engagement in the care of patients with long COVID. And they have impaneled a multidisciplinary expert panel. I serve on this panel along with several others in this room and many more. And they're partnering with relevant clinical societies to develop, review, adapt, and disseminate clinical guidance and educational resources. And this will only grow over time as we have more resources to share. And so these are some of the organizations that are actively partnering. I'm proud to say that the American Academy of Pediatrics is here, so we can start to spread this through our pediatric primary care networks. But they are working to get this information and share it on websites, blogs, newsletters, sends it out to their chapters through webinars, and so more to come from these different organizations in this partnership. And there are QR codes and links for where these references will live, and they can be accessed by primary care providers in real time. And so I wanted to end my talk today really talking about where we need to go and the fact that children are suffering and that we really need treatment. We all know that. It has been too long, and that pediatric clinical trials are urgently needed. And I'm going to share some slides with you, but it's really bleak in pediatrics is that we have hardly any clinical trials focused on children, and this needs to change going forward. And so I'm going to start with just two small, kind of smaller clinical trials that have published recently. One came out of Poland, where they were really doing a 3-arm small trial about different supervised exercise training programs in order to enhance exercise capacity and fatigue. And so they were comparing exercise that happens in a pool called aqua with exercise that happens on land to a control group. And they saw small changes in oxygen capacity when they looked over time in both of the exercise groups, and some small increases in oxygen capacity in the aqua group compared to controls, and no differences in fatigue or quality of life. Another very small study in Italy was looking at supplements, L-arginine and vitamin C, with the goal of improving endothelial function and reducing oxidative stress. They showed some improvement in quality of life and respiratory function, but this is very small. There were 12 children in each of the arms. And so other than that, there's really a dearth of registered studies. So we saw in adults that there were hundreds. Here we have 3 that are small studies that seem to still be recruiting or nearing completion. There's 3 others that it's really unknown what their status is right now. You can see these numbers are also very small, and 6 studies that include all age ranges, mostly adults, and it's really unclear if any children have actually been enrolled. So much more is needed. I'm gonna end with talking, Recover Treating Long COVID initiative has been coming together to see what the next phase of clinical trials will be, and really emphasize that they're going to include children in these trials rolling out. And so there was an extensive process to select the next set of trials. People submitted their proposals. The vast majority came from the patient community. There were agent selection groups, and now there are small protocol working groups. And 4 interventions were selected for the first phase of this. And we're really happy that these include children. So the first one here, low-dose naltrexone, is going to be a large-scale pediatric trial. And the second one, the LGP1 receptor agonists, will likely include children starting at age 12. And then the subsequent 2 will focus on adults. So low-dose naltrexone acts as an opioid antagonist. It is theorized to reduce the release of pro-inflammatory cytokines and modulate microglial activity. It's been effective in reducing chronic neuropathic pain in related conditions, such as fibromyalgia, and has relatively few side effects, maybe headache, tachycardia, and vivid dreams. And in the pediatric community, there was incredibly strong interest in doing a pediatric trial on low-dose naltrexone. It is used much less frequently in children than in adults, partially because of significantly reduced access. We have very few long COVID clinics that focus on children. And in general, pediatricians don't prescribe low-dose naltrexone. We don't have the evidence and the trials in children to make physicians feel comfortable that it can be used widespread in children for this reason. And also for children, it's very difficult to access because it's only available through compounding pharmacies. And so the trial is going to enroll eligible individuals that will be randomized to receive the LDN versus placebo. And we're aiming to have 1,300 children enrolled, distributed across 3 age groups: school-age children, adolescents, and young adults. And I highlight that because we know from what I shared before that long COVID looks different potentially in different age children. And it's important for us to be able to study whether therapeutics will respond the same way in these different age children. The primary outcome is going to be to reduce fatigue severity by 16 weeks, and secondary outcomes will include hoping to improve quality of life, reduce functional disability, reduce pain, and improve cognitive function. And so where do we go from here? It's been 5 years since the onset of the pandemic, and we have no approved treatment for long COVID in children. These are really non-existent. And so our trials really need to focus both on symptom relief in children as well as addressing the underlying mechanisms. They need to be able to accommodate the remitting and relapsing pattern that we see in children. We need to learn from the adult studies and adapt for children. We need to accommodate the findings that are coming from ongoing mechanistic trials. And we need to continue to do in-depth characterization of long COVID in children so that we have the foundation to develop novel therapeutics. And so I'm going to end with key principles for pediatric long COVID trials. First, we need dedicated trials specifically for children because they experience different symptoms and phenotypic clusters. We need different interventions potentially depending on the age group, and we need clear, relevant pediatric outcomes. Second, we need dedicated pediatric resources to do this. We need groups that are highly invested in prioritizing pediatric interventions on an ongoing basis, and we need dedicated safety monitoring boards and coordinating centers with pediatric expertise. And I'm going to end with the need to be consistent with NIH policy when we're thinking about trials. So NIH policy says that any new adult trial should include children when appropriate. And so studies really need to justify why they're not including children if they don't. And this is especially true for children 12 and older when it's scientifically and clinically appropriate. And I'm just going to end with a quote that we've been trying to disseminate, which really highlights this urgency, in that we need to protect children through research, not from research. So thank you so much. I just want to acknowledge that this is a tremendous group effort and to thank all of the participants and families, our recover sites around the country, as well as our representatives, the NIH for their support and funding, and the numerous organizations that are involved in our work. Thank you.